Well, welcome to the Ending Parkinson's Disease webcast series. We're trying to get to the voices of Parkinson, and as you probably know, there's a new book out here called Ending Parkinson's Disease, and we're talking a lot about the PACT, prevent, advocate, care, and treat, and talk about the stories of polio and HIV and what we need to do to get our act together in Parkinson's disease so we can move forward and really change the outlook and change the trajectory. And so we're just so happy to have you here with us and on our webcast series. And as we discussed a little bit before, this is going to be an informal discussion. I'm opening up a chat box right now. There's a chat function here on the bottom, and so people will be able to send in questions live. And today's topic is we're going to talk a little bit about deep brain stimulation, which is one of the device-based therapies that has really changed a lot of what we do in treating this disease, and it's created a lot of excitement, but also we forget about the people that have become bionic. And so you're one of the bionic generation, and so we're just so happy to have you here with us today. And we'll record this so people can watch it as well. And we'd like to pick your brain and learn a bunch of stuff about you and about deep brain stimulation. So does that sound reasonable to you?
Yes, first of all, thank you so much for the invitation. I feel honored to be part of your webcast since you have done so many important people interviewed. I saw the astronaut, I saw Dala, Ali. I see you're gonna interview some Olympic winners, bicycle, I think. So I'm honored to be part of your panels and can help people with Parkinson's like me.
That's terrific. That's terrific. And tell us a little bit about yourself. Tell us who you are, where you were born, what was your name when you were born, and where were you born, and tell us just a little bit about you. We'd like to know a little bit of your history. Who are you?
Okay, my name is Keila del Manzano Lopez. We use our two last names here in Puerto Rico, Manzano Lopez. I was born in San Juan, near the beach, Puerto Rico. So I love the outdoors. My parents are happy persons that love the outdoors. So since I was little, I was in the beach. I was doing outdoor sports. My dad has always been very active, so I learned with him how to run motorcycles, run go-karts. I did scuba diving. I learned how to fly planes, like line planes. So I'm a very active person thanks to my parents. And so when I got Parkinson's, imagine, I thought what's going to happen with all these things I do, but nothing. I thought about that later. I studied here in Puerto Rico. I have an MS, a bachelor's in science, biology. And that's all like about me. I'm a happy person and I love life. I like doing all of things.
Fantastic. So let me ask you a couple questions here. I'm sure people are wondering here as the questions are starting to come in. What's your favorite filling for empanadas there in San Juan? What's your favorite filling there?
Panadillas. I like the chapin. I like crabs, lobster. They're really nice.
Okay. Fantastic. And what sports do you all watch over there? Are you baseball fans, football fans, soccer fans, or?
No, I'm mostly a tennis fan. I played tennis. I used to play league, category 3, and I love tennis. I play pickleball. I like it also. But mostly the basketball. My husband played basketball when he was young, so he likes to see basketball.
So you're active. We could say with certainty that with your Parkinson that you're a very active person.
Oh yes, like I said, I have Parkinson.
And Tell me,
Parkinson's not gonna stop me. So
so tell us a little bit about your Parkinson. What was your first symptom and when were you diagnosed?
okay, I was diagnosed in 2005. I was 48 at that time. Now I'm gonna be 63. And it all started with my right side, my right arm. I like got some tremor in some fingers, and my wrist and my elbow started hurting. And I couldn't deal with my right arm like I should. And then we like to go, and I started feeling, you know, when you go to see a movie between the ads and the they give you like sitting about 3 hours in the theater. When the movie ended and when I started to stand up, my leg was like cramped. And I almost couldn't move my right leg also. Everything was the right side. So I went to begin with. I went to a physiatrist, and I was with that doctor for about 6 months, and so that nothing could be done with me. That I didn't get better. She referred me to a neurologist, and then on October 2005, the neurologist concluded that I had Parkinson's. Then after that, I was well for about 8 years, 2005 to 2013. I was doing well with the medicines and everything. I kept with my life as it was normal. For 8 years, I played tennis, I did the water sports and everything, but eventually I started getting more rigidity. I had cramps. I had during the night pain in my back while sleeping. I couldn't even turn from one side to the bed to the other. My husband had to help me. I remember that doctor used Botox for me in my back. It didn't help. My trunk was getting more rigid also. And the most important thing was the wearing off and the freezing I got. That's what bothered me the most. The wearing off, I was still about 1 hour for the next dose, and I wasn't working, and it just froze. I couldn't walk. I wanted to walk, and I couldn't walk, but I could walk backwards.
Okay, gotcha. So I'm going to read you an excerpt from the Ending Parkinson's book, and I want you to just tell me if you can identify with this. And the section here is called The Potential of Deep Brain Stimulation. And it reads, Frida Falcone is a successful Peruvian sculptor in her 50s. Her husband, Marcus, a multinational businessman, were enjoying a good life together. Then, quote, Mr. Parkinson, as they referred to it, knocked at their door. As the illness took increasing control over Frida, her ease of movement and artistry disappeared. Medication helped, but only temporarily. And when her levodopa kicked in, her tremors would fade away. But over time, she needed to take the drug every hour. So when I read you Frida's story from the book, and it goes on to detail her story of becoming bionic and what it meant to her, tell me, does that resonate with you? I mean, do you identify with this Peruvian sculptor?
Oh yes, 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 because she had the tremors. I've never had tremors. I always my worst symptom has been the freezing, and that's desperate. Wanting to move and don't be able to move. I mean, I identify with her because it keeps you from doing all things you want. I was lucky that I could walk backwards. You don't explain why I could do that. So if I couldn't move forward, I just started walking backwards. I remember people looked at me and they laughed and said, "What happens to this woman?" You know, and I just said, "Sorry, I have to do it." And one day I was in church, I remember, and we were going inside the church, and suddenly I couldn't walked forward and started walking backwards, and the priest told me, "Everything fine, ma'am? It's okay, no problem." And one day we were also on a casino in a hotel. Same thing happened to me. I couldn't walk forward, so one of my friends just walked backward all the way. But it was time to do something because life has to go on. And
Absolutely.
yes,
Absolutely.
so
And
yes.
so I want to mention to everyone, we're getting lots of people logging on here, that our web chat is open here. The chat box is open at the bottom of your Zoom. So if you want to ask Keila any questions, our topic today is on deep brain stimulation, and she's going to tell us a little bit about the process, how it works with screening and what it's like, and what her symptoms were before and after, and what some of the struggles are. And really, we've got some time that we can chat about anything that you want to chat about. And so I want to ask you, so what was it that made you pull the trigger? I mean, honestly, to let somebody, like Dr. Foote, drill a hole in your head, you gotta have. So what was it that you said, maybe I want to let somebody drill a hole in my head? What was the point? What was the trigger that made you say, maybe I need to do something, a little bit more to get a hold of this disease?
I was almost incapacitated. I had to use a cane. I had to use a walker because I just couldn't move. So do I do it or do it? Because I remember it was scary surgery because it's not easy. But if I didn't do it, I wasn't gonna have quality of life. I wasn't able to move. Every morning I just woke up with my toes cramped up like this. And my husband had to pick me up, put me in bed, and my medicines. And when the wearing off came, so I had to stop doing everything, just sit in a chair, all cramped up and frozen, and waiting for my next dose. So where was I going to be? And that was at that moment, those symptoms, during my 2 years afterwards, maybe I was going to be in bedridden. So I just started looking up and looking for Dr. Food and everything, and looking YouTube, people that have done the surgery to see how they are done with it. So I tell you, I was really scared, but I had to do it.
So we talk a lot in Ending Parkinson Disease about that divide, between the haves and the have-nots, and the people who have access to care and the people who do not. And I speak for my co-authors when I say that I'm disappointed. I give ourselves an F plus, or an F minus, not even an F plus. That would be too generous for giving access to care. And we know, when it comes to deep brain stimulation, we know that the access to care, even for underrepresented and for minority populations, is even worse. And so it's hard to get care. So you find yourself on the island in Puerto Rico, and you decide, you're thinking, maybe I need to do surgery. So what kind of access do people in Puerto Rico have, and how do you bridge that? I mean, what was your strategy to get access to care?
Okay, I was lucky. My husband is a doctor, is an internal internist, and my healthcare is triple S, Blue Cross Blue Shield. At that time, they didn't do that surgery in Puerto Rico, so thank God the people talked with them and they approved the surgery. And I was lucky. I was one of the lucky few that could go over, and they covered almost everything from the surgery. And they have even covered the after the checkups and annually and everything. So I was lucky enough in my case, the healthcare insurance I had covered for it.
Yeah, that's it's very fortunate, and I think you're probably in the minority in terms of people, and also to be able to go back and forth, and to be able to afford the flights and all the things that it takes to get the adjustments. And so one of the futures here of deep brain stimulation, and one of the things, just to tell all of our viewers here, we talk a lot about the book, and it's Prevent, Advocate, Care, and Treat. And Treat is in developing new treatments, we are now developing and a nice collaboration with Tsinghua University, which is the Chinese MIT. In the US, we have a paper out in movement disorders this week about Bluetoothing to be able to adjust people in their homes, but getting people access to care. And we have a National Institutes of Health grant that does this, that is in its 5th year, trying to help to bridge that access and get nurses and people out to the houses. And now, the COVID crisis has created a catalyst, for telemedicine and for home health. And so now you find yourself, you're going from the island, you're able to hop over, you get over to Florida, you find Dr. Foote, and then you go through a process of screening, because as you know, not every patient at any time point in the disease is a candidate for deep brain stimulation. So if you take people from beginning and on their course of Parkinson, there's a window, and we wrote about this in the Journal of the American Medical Association recently with Dr. Melissa Armstrong, a nice review. There's a window, where any Parkinson patient might benefit the most from any therapy, whether it's a medicine or a surgery. And so there's a window here, when you're having symptoms. And part of that window you described is you're taking medicines every hour or two, you're wearing off, but when the medicines kick in, you're getting a good effect from the medicines. And so for people that are out there saying, am I potentially a candidate or not a candidate, those are key aspects. When the medicine kicks in, do you get better? Normally the gait, the walking, the balance, and there's a question about how your balance was before the operation, but normally those things don't improve that much with DBS unless when you take the medications, your gait and balance get better, and that's the minority of patients. So just to answer, this is Sue Van Dahl. Welcome, Sue, for a question. Sue wants to know, what was your balance like before you had DBS? Because Sue and others know and have been told that balance doesn't improve much from this technology. So tell us about your balance.
Okay, the balancing, that's right. What helped me most with DBS was my freezing. Walk. The balance, as you say, doesn't have much, but it has gotten better. The thing about balance is that you have to be aware of how you move. I can do everything better now, but I can't move. I can't do sudden movements. I'm going to turn around or whatever. You have to be careful. Think about the way you move. But as my freezing improved, I just don't freeze anymore. Well, I'm in the right moment working with the system and raising the balance. My balance improves also, because when your movement improves, you can walk better and move better. Then your balance is gonna get better. So, as you say, you said that DPS doesn't work in the balance, but if it helps you with freezing, if you're freezing, indirectly it helps the balance also.
Yeah, so that is an outstanding point. Thank you for correcting me, and let's clarify that for people that are on the line. So we generally don't want to overpromise, right? When you're going to do an operation for people, you don't want to overpromise. But we do know now, in looking back through collective literature, that about a third or more of people who are freezing up are going to have improvements in the freezing. Maybe not all the way better in all of them, but in some, it's going to get better. And the presumption is, again, if you're responding well to your medicines before DBS, what you want to do is you want to get a better on without dyskinesia and without wearing on and going off, these on-off fluctuations. And so if your walking gets better because you're not dyskinetic, because you're on more, then it is possible that you'll see some indirect effects on balance, but not direct effects. Now, one of the other things, and I know this is going to shock you, but we wrote another book that just came out. It was caught in the warehouse in Canada from Robert Rose Publishing in the COVID crisis, but I'm told this week that it's out and available. It's called Living with Parkinson's Disease, and in there's a whole bunch of charts, because Robert Rose is like they publish a lot of cookbooks and things like that, so it's kind of a cookbook of all the things and tricks for Parkinson, written by Dr. Malati Deeb and I. And in there is this notion in one of the call out boxes of questions that you should ask your doctor. So we say when you go for this evaluation, it's more than just a single evaluation. One of the questions was getting at this. We have another question. It was getting at this idea that, like, what do you ask during the evaluation? And is it, what is this interdisciplinary evaluation, and how do you qualify for it? It's not like, a gallbladder surgery where you show up and you're like, oh boy, that gallbladder needs to come out. We'll see you on Thursday, and they do it. So we talk about in living with Parkinson, we talk about the screening questions. And so we say you should be prepared to answer the following questions. Can you list in order the symptoms that are most disabling to you? And the reason we call that out is because we learned the hard way from the school of hard knocks, from doing this for 20 years. Dr. Foote and I learned if you don't actually ask the patient what they want to get out of the surgery before you evaluate them, you might erroneously do a surgery knowing they're going to get better. But if they don't get better in the areas that are important to them, then they don't get better. And we ask what Parkinson's symptoms must get better to make it worth it for you to have surgery. So let me ask you that, because I think people are interested in this general topic. First, tell us a little bit about what's the evaluation like. You don't just swoop in and out for an hour with the doctor. Like, what's it like to get the evaluation for deep brain stimulation?
I remember, just like you said now, when Dr. Food asked me that same question, give me the 5 symptoms that most bother you. Said about the freezing was the first one. I remember the pains I was having at night during my sleep. The joint pain, the back pain, the cramps, the rigidity. And I mentioned, I think there were 6, and the food told me, okay, we can help you. Because as you said, if I didn't have the things that DBS could help, then I would have been a candidate. So I was one of the lucky few that I was healthy. I didn't have at that time any other thing or anything, and I qualified for the surgery. So I was lucky that the things I mentioned, you could deal with them. And
Yes.
fast track came and everything else.
So tell us about the fast track. I'm looking at a picture here in the book of this thing called fast track. It was something that was a coin term back by Dr. Foote back in 2002. But a lot of centers have realized, that you have to have the correct workup. So how many people did you see, and what was the purpose of all of these people, buzzing around you?
Okay, I remember I saw a psychiatrist, but that had to be done in San Juan because of the health insurance. The coverage here was not there. And I remember also a psychiatrist saw me over there in Gainesville, and saw me Dr. Rodriguez, the neurologist. You have to be sure that the person is qualified for the surgery. I remember the psychiatrist that you are sure of yourself. You don't have any bad thoughts about life or whatever. You have to be stable emotionally for the surgery to be done, to be qualified for it. And well, I got my interviews. I did well in all of them. Then I remember when Dr. Rodriguez told me, if you were my sister, I would tell you, do this now, don't wait for later, because it will benefit you. We can guarantee you quality of life. That was 100% true, quality of life, got my life back.
Gotcha. Now, Sally Swope has a question for you, and I'll just remind everybody our chat box is open, so you can ask Keila anything you want. She'll even tell you about her favorite empanada filling if you want to know about it. But Sally wants to know how did you manage coming off the medications, because you have to come off the medications, for 12 or more hours, and it's very painful for some people. How did you manage that during the workups and during the care?
Yes, that wasn't easy. I remember for the first appointment, the doctor told me you have to come off medications. And I had never been off my medicines. In 8 years, I've been diagnosed. And I took them the night before, and in the morning I started feeling funny. And then also all of a sudden I started cramping up and everything. I remember I just took one Cinemed hidden so I could get over to where you were. I was in Ocala. But it was not easy. And at the time of the surgery, I was on medication, and I remember during the surgery, I got so nervous. My toes started to cramp, but there was a resident there. He just took my foot for all the surgery, I remember. And he just started massaging it. I couldn't see his face because he was covered. But I was in pain and everything, but I had to do it. I had to hold up.
Okay.
Hold
And tell
on.
us a little bit about your fan club here. They want to know a little bit about what it was like to get the multi-hour neuropsychological testing. So as you know, we have people routinely see a neuropsychologist to look at your thinking, a psychiatrist for your mood, you know, rehabilitation therapists like physical occupation, speech and swallow therapists, a neurologist, and a neurosurgeon. And we have patients go on and off their medicines. And then we get together and we talk about you behind your back, which I know sounds horrible, but the highest level of healthcare that you can hope for is when a group of healthcare professionals actually get together and talk about you behind your back. This is like what you want to happen. This is the greatest, highest level of care, so they can make decisions about target approach. Do you need one lead? Do you need two leads? You know, what's the best way to accomplish the surgery? But the question that comes in is they want to know, you know, because they know these neuropsych evaluations are many hours long. How did you get through that?
Well, when you're going to do something like DBS, you have to be open to everything, and you have to be calm. You have to hold on, as I tell you, and uh, you have to do your best. Uh, so the outcome is best for you. But it wasn't so rigid or so rude. I remember I had an interview with a psychiatrist. I remember when they started doing the physical exams. You know, you have to be positive if you want to go through and come with a good outcome.
Yes. So I'm gonna come back here to the story that we started with, and we were talking about Frida Falcone, who is the Peruvian sculptor. And I'm just going to read a little excerpt here. Numerous studies have shown the benefits of the surgery, which has become part of the standard Parkinson's care in many regions of the world. And of course, you're from Puerto Rico. There are risks, including bleeding, infection, misplacement of the lead, and very rarely death. To date, over 200,000 patients worldwide, including Frida Falcone, have received the surgery. And for Frida, the surgery was a success. She's back to sculpting and jokes that she has divorced, quote, Mr. Parkinson. The improvement in her movements and quality of life are not permanent, but they can be life-changing, and she counts herself as one of the lucky ones. So when you hear that, how do you count yourself after having a surgery like this?
I feel blessed. I'm one of the lucky ones also because as she says, I had my life back. I couldn't imagine the outcome would be so wonderful. Let me tell you, I cherish the hours during the day when, like, I'm in my peak moments. That the DBS with the medicines are working all right. I feel like I don't have the disease. I go out and I walk. If I want to swim, I swim. If I want to paint, I paint. You know, everything working all right every day as it does. Usually, I'm not a morning person, but usually from like 10 o'clock in the morning until I go to bed, I'm working quite well, so I can do almost anything I want. I told you I'm a very active person. Sometimes, if I don't like the color of the room, I paint the room. If I don't like how the furniture is, I change the furniture. My husband has told me, you know, I had to change some things. Like I love roller coasters. Now I can go to roller coasters. I like the, you know, taking waves in the dish. I have to be careful now. Maybe now I see that put my feet in the water, but I can do a lot of things. I have changed the things I did for other things now. Like I started doing more manual things. I started doing jewelry. I started doing wood burning. I started doing PVC birds. You know about those, working with my hands. But DBS just brought me back to life.
So it sounds like you
No
would.
more, no more freezing, no more walker. I like walking. I did my walking stick. So I was walking every day, almost every day. I like to walk around an hour daily to do that. My exercise to help me. I like going to the swimming pool also. So I don't regret having done the surgery at all. Sometimes you don't feel well. Sometimes my stars hurt. I have 27 on each side. My chest, I have to be careful if I do. I can't do things that if I too much energy with the chest area because then my transmitter area hurt. But apart from that, I don't have any bad regrets about PBS. On the contrary, 100% thankful for it. So don't be afraid. If you have to do it, do it. There are the risks. The only thing I didn't like too much was that you have to be, alert most of the time. And when you hear that drill in your head,
Yes.
it's not so fun. But
So I'm going to address a couple of questions here that came in. So Amy Lindbergh, thank you for your question about freezing and practical tips and carrying a laser pointer. I remember I took care of a race car driver who many years ago, it's probably a couple of decades ago, would use the laser pointer as a visual cue in the airport, and that was a really nice way for him to walk. I should have really been thinking forward. I could have started a company because, as you know, there are companies now that do these cues, and for some patients cueing does help, for some patients it doesn't, and sometimes even the cueing can make it worse. And so it isn't always a panacea, but it is something to do. And remember, about 20 to 30% of people with DBS get some meaningful benefit in their freezing, and the best way to predict it, if it's going to happen, is do you improve at your best medication on? So an hour after you take a dose of medicine, or maybe a little bit more than your typical dose, do you stop freezing? And that is one way that we think could be helpful. We never promise it with DBS, but certainly in Keila's case, you hear it here. So I don't want people to get over optimistic, because she's a super responder and she's definitely one of the lucky ones on that. But since the DBS, she hasn't been really troubled by the freezing like she was before. The other question is how to select a good doctor for DBS, and how many DBS operations should a doctor have done? Thank you for that question, Jim Cosper. So we talk about this a lot, and we over the years have worked a lot with the Parkinson's Foundation, who is co-partnered on a lot of our projects. And you can see here, I've got the Parkinson Foundation pin. I've been the medical director since 2005. We have a lot of, or 2006, we have a lot of information up on the website on just this, but we opened this 1-800 for the number 4 PD info. Remember, before everything was digital, all the numbers on the telephone had letters associated with them. So 1-800 PD info, if you're old enough to remember that, and the old dialing phones. If you dial that, we have nurses that can help you to tell you where qualified centers are, where centers of excellence are, and help to connect you. But you should always interview your center where you're going to do the surgery and figure out, what are the logistics. And we talk about one of the big hurdles for Parkinson's disease is getting patients care and getting care into their home. That's why we're so excited about Bluetooth technologies. We're also excited about new technologies. So we're beginning in our lab. For many years, we've looked at where tics come from and where different symptoms and tremors come from. And so there's a whole bunch of us who are interested in developing these technologies called closed loop technologies, where we'll be able to read your brain signal. So Keila's in Puerto Rico, and I'll be able to watch her brain signals and in real time make changes, and even have the computer teach the computer how to make changes. And we've done this in patients with Tourette and now in patients with tremor and in Parkinson's. So I think that that's coming. I think that when you interview your doctor, you should understand like what they do, what's their reputation in the field, how many have they done, and what is their quality process? Do they have an interdisciplinary team? And is it over for them once the leads are in? Or do they have a way of telling whether you got the right result? Or do they do regular imaging? Do they go through a quality assurance to make sure the leads are in the right place? And so the more experienced teams do these things. And so dialoguing, and some people will actually interview a few teams, before they go. I know in this book, Frida Falcone and her husband recounted the history. I forget if it's 5 or 8 different centers that they traveled, and they interviewed a whole bunch of different people before they selected a center. So it is a process. There are a lot more people who are qualified. Look for centers of excellence and look for experience. Now, I want to come back to Keila because I want to ask you a question, because you mentioned that you're a swimmer, and as you know, in the New York Times, there was an article that came out that said that people after DBS were having trouble swimming. And so since you were a swimmer, I'd like you to sort of recount what your experience has been with swimming before and after DBS.
Okay, I know that after the surgery, I always told my husband that I felt different swimming. Like I didn't feel like I did before, but I had never turned off my DBS. I'm not come to do that unless you do it over there while checking me. So for the first time last week, as you told me, I turned my DBS off here in my house, something that I had never done. I do it in the checkups. And suddenly I went to the water and I felt like a loser swimming. When I went into the pool, my arms felt better. Then I turned the DBS on again, and I felt like a pull on my muscles. I told my husband, I feel freer swimming with the DBS off or in the water. I mean, we sit on. So for the first time in 8 years, I think that DBS like kind of holds me a little bit while swimming. Better off. So
So it's a very interesting observation. So the New York Times had a piece on a study that came out of Europe. I believe it was either Germany or Switzerland, but at any rate, it was a study where they looked at people, and it wasn't systematic. It was just people who had reported that they had swimming trouble, and they went back and they tried to gather as much information as they can. And so in your case, we had you turn on and off the stimulator. We've got that test, right? And your coordinated movements are better when you're off the stimulator than when you're on. Now, a couple of points here. We don't understand why that is. It's not necessarily just a matter of the current spreading into some of those motor regions. And so we're studying the brains we're studying your brain and other people's brains to understand what the pathways are, because sometimes we can disrupt pathways that we don't intend to disrupt. And so it's important that all patients with Parkinson know you should never swim without somebody with you, no matter if you have DBS or not. But not everybody with DBS actually gets worse, with their swimming. We need to understand who's getting worse and turning it on and off if you're a swimmer, and making sure that you never swim alone, whether you have Parkinson or not. We have seen drownings in patients with Parkinson because their meds can wear off and they can become stiff and frozen. So always making sure that you have a person with you. Now, we have another question for you from Deborah. Deborah wants to know, did you return back to your carbidopa levodopa medications after the DBS, or did you drop your medicines, or what happened to the medicines?
Yes, I'm on Cinemed, I'm on Entacapone and Select. I have been able to lower my dose a little bit, but I have to use medicine. So don't think that you're gonna have DPS and don't use medicine, because you have to keep on with your medicines. But maybe lower a dose. And I use some patches. I don't remember the name of the medicine that was a patch. That one I don't use it anymore. I'm just on my Cinemed, the Entacapone, and the Select. But I have to use medicine. The thing is that I don't have like wearing off, because I have been 14, 15 hours with some medications. When I go to the checkups, I go there walking by myself 14, 15, 16 hours of med. So the DBS helps me move around.
Yeah,
Right.
so that's a great point. I want to make sure everybody that's listening catches that. The goal of DBS isn't to reduce medicines. In some cases and in some DBS targets, you'll decrease medicines more than others, but also medication decreases can also lead to neuropsychological effects. We know that now and have published a lot on this, and other groups have published on it: apathy, depression, gait problems, freezing, other issues. So don't be overly aggressive with the medication reductions as well. And the goal isn't to get rid of the medicines. The goal is to make you as good as you can. So at the end of DBS, the goal here is we want to increase your on time, which means decreasing your off time. On meaning when you feel on, when the medicines come on. We want more on time. We want it to be smoother. We don't want you going up and down with those on-off fluctuations. DBS is outstanding for tremor, great at suppressing dyskinesia, and it only helps the freezing in about a third of patients, and the walking and balance, maybe, depending on how you do when you're on your medicines, and that might progress over time. We do know that the little caveat that we learned recently: in some but not all patients, swimming can be made worse. Now, there's a question coming in from Gary Ballinger. Thank you, Gary. He wants to know, he's had a friend, it didn't work out well. How do you know when it's not, when it, enough is enough and you should just give up? Well, we have piloted and published on the idea of DBS troubleshooting and developing a DBS troubleshooting clinic. We published this in the Archives of Neurology back in 2005. It was when people were referred into us who were having DBS failures, quote failures. They didn't get what they thought they were going to get. And so we've done a lot to try to understand this phenomenon. And part of it was what we did at the very beginning. What are the symptoms you want to get better? And then we have this back and forth conversation with the team to make sure that the expectations are met. Now, when all those things are equal, when we bring in patients, and we've seen over 500 cases from all over the world with DBS problems. I call Dr. Foote the DBS plumber. He prefers electrician. I prefer plumber. But at any rate, we take a look at that, and it can be the hardware, it can be the expectations, it can be the programming, it can be the lead location. It's the lead location in half of the cases. And so getting a systematic workup to look at imaging and outcomes and see how it goes across the different areas of the brain is important. And another question that just came in was, my doctor did 1,200 operations, so I thought he knew his way around the brain. Well, it's not quantity in healthcare, and we know this because you see some patients and some doctors and some clinics that are doing 1 million back surgeries or 1 million gallbladder surgeries and having very bad outcomes. And so it's not necessarily the quantity, it's the quality of the team. Do they have an interdisciplinary team? Are they careful? Do you trust them? And are they going to be there for you, to help you through it, in terms of the programming? Because it's not a light switch. It takes several months after the operation to get the device programmed, but then it also becomes part of bringing back in the physical, occupational, speech, and swallow therapy, adjusting medications, and moving forward. So this has been a wonderful session, and we want to thank Keila for opening up and sharing with us on the Ending Parkinson's Disease webcast, the Voices of Parkinson's. And we have some really super exciting speakers, but I just want to correct you that you're just as much as a celebrity as anybody else that we've interviewed here on the program. And Parkinson's disease, it doesn't pick on any one culture or any one country. It's a multinational problem that we all suffer with, and that's part of the idea. We need to prevent, advocate, care, and treat to end Parkinson's. So thank you so much for spending time with us today. It's been a real honor and a pleasure.
You're welcome, and let me tell you, I was lucky to be in your team. I don't know if I was lucky also because I've been so successful with the DBS. Since you first sent me the system, I think we have just to adjust it to a few times. I've been one of the lucky ones that haven't needed so many adjustments. And also very important, I wanted to tell everybody that this is a family thing. If you're going through this, you have to have your family besides you, because alone you can't do it. You need to have people around you that love you and will take care of you no matter what. And in my case, I think I have been lucky because I was with your team. I've been lucky because I have responded so well to DBS. And I've been lucky because I've been surrounded by my husband, my parents, or my family, that they have given us the support you need to go to be successful and go on with your life. Because it helps you, but at the beginning it's not easy. As you say, it's not an easy surgery. You have to have the recuperation isn't easy also. So you need to be surrounded by great people who love you, and we have a great team like you have. I have gone.
Thank you.
So
It's an
thank you so
honor
much
and
for questioning.
it's just an honor, been an honor and a privilege to have you on. We want to thank all the questions that came in. If your question didn't get answered, I'm going to ask Abigail to get your information, and I'm happy to answer those questions and get those back to you through Abigail by email. Thank everybody. We'll see you back here for more Ending Parkinson webcasts, and hopefully you'll come back and visit us soon and give us an update. So have an awesome day.